Welcome to Pediatric Case Review. Today we present a comprehensive case-based lecture on Meconium Aspiration Syndrome, covering clinical presentation, diagnosis, and management. This condition remains one of the most challenging neonatal emergencies, affecting term and post-term infants, and requiring rapid recognition and structured intervention at the delivery room. We will work through 15 carefully designed clinical cases covering all key aspects, including pathophysiology, examination findings, severity classification, investigations, treatment, complications, and long-term outcomes. Let us begin. Case 1. Initial signs. A term infant of 39 weeks gestation is delivered through thick meconium-stained amniotic fluid. At birth, the infant is non-vigorous with a heart rate of 88 beats per minute, minimal respiratory effort, and cyanosis. The APGAR score at 1 minute is 4. What is the most likely initial clinical presentation of Meconium Aspiration Syndrome? Option A. Transient tachypnea of the newborn. Option B. Meconium Aspiration Syndrome with respiratory distress. Option C. Congenital heart disease. Option D. Neonatal sepsis. The correct answer is Option B. Meconium Aspiration Syndrome with respiratory distress. This diagnosis is supported by the classic triad of tachypnea with respiratory distress, minimal respiratory effort, and cyanosis. The infant was delivered through thick meconium-stained fluid and presented with a low APGAR score of 4 at 1 minute. Immediate respiratory distress is the hallmark of this condition, as meconium causes airway obstruction and chemical pneumonitis. Early recognition signs include thick meconium-stained amniotic fluid at delivery, a non-vigorous infant requiring immediate intervention, respiratory distress within the first hour of life, and cyanosis despite initial resuscitation efforts. Case 2. Identifying characteristics. A full-term newborn develops progressive respiratory distress within 1 hour of birth. The infant exhibits tachypnea at 68 breaths per minute, nasal flaring, and subcostal retractions. Chest X-ray shows hyperinflation with patchy infiltrates. What clinical feature is most characteristic of Meconium Aspiration Syndrome? Option A. Hypotonia and lethargy. Option B. Diffuse patchy infiltrates on chest X-ray. Option C. Cyanosis with a normal chest X-ray. Option D. Bradycardia and poor perfusion. The correct answer is Option B. Diffuse patchy infiltrates on chest X-ray. The radiographic appearance in Meconium Aspiration Syndrome progresses through 3 stages. In the early stage, from 0 to 6 hours, there is hyperinflation with a flattened diaphragm due to air trapping. In the progressive stage, from 6 to 24 hours, patchy infiltrates appear as chemical pneumonitis develops. In the severe stage beyond 24 hours, diffuse opacities develop with possible air leak complications. The characteristic patchy appearance represents areas of atelectasis alternating with hyperinflated regions, which is the hallmark radiographic pattern of this condition. Case 3. Physical signs. A 38-week newborn is intubated due to severe respiratory failure following meconium aspiration. On physical examination, the infant demonstrates significant respiratory distress with a distinctly barrel-shaped chest configuration and widespread bilateral crackles on auscultation. Thick meconium is clearly visible in the oropharynx and upper airway. What physical finding most specifically suggests air trapping due to partial airway obstruction in this case? Option A. Flattened diaphragm visible on chest X-ray. Option B. Barrel-shaped chest with hyperinflation. Option C. Decreased breath sounds on the left side only. Option D. Asymmetric chest wall movement. The correct answer is Option B. Barrel-shaped chest with hyperinflation. This is explained by the ball valve mechanism. Meconium creates partial airway obstruction that allows air entry during inspiration but prevents air exit during expiration. This ball valve effect leads to progressive air trapping and hyperinflation. The physical examination findings include a barrel-shaped chest where the anteroposterior diameter increases due to air trapping, hyperresonance on percussion over affected areas, decreased breath sounds in hyperinflated regions, a flattened diaphragm visible on chest imaging, and increased work of breathing with intercostal retractions. An important clinical pearl, the barrel chest in Meconium Aspiration Syndrome develops rapidly due to severe air trapping, unlike chronic conditions where it develops slowly over time. Case 4. Severity classification. A term infant with Meconium Aspiration Syndrome has an oxygenation index of 32 and requires mechanical ventilation for more than 48 hours. The infant also has signs of persistent pulmonary hypertension of the newborn with right-to-left shunting through the ductus arteriosus. How would this case be classified in terms of Meconium Aspiration Syndrome severity? Option A. Mild Meconium Aspiration Syndrome. Option B. moderate meconium aspiration syndrome. Option C, severe meconium aspiration syndrome. Option D, critical meconium aspiration syndrome. The correct answer is option C, severe meconium aspiration syndrome. An oxygenation index of 32 with mechanical ventilation beyond 48 hours plus persistent pulmonary hypertension of the newborn clearly indicates severe disease requiring intensive management. According to the severity classification criteria, mild disease has oxygen requirements below 40%, duration below 24 hours, no complications, and an oxygenation index below 15. Moderate disease requires a fraction of inspired oxygen between 40 and 60% or continuous positive airway pressure support, lasts 24 to 48 hours, may have air leaks, and has an oxygenation index of 15 to 25. Severe disease requires mechanical ventilation, lasts beyond 48 hours, has complications including persistent pulmonary hypertension and pneumothorax, and an oxygenation index above 25. Case 5. Auscultation. A newborn with Meconium Aspiration Syndrome is being evaluated in the neonatal intensive care unit. On auscultation, you hear widespread wet inspiratory crackles and expiratory wheezing throughout both lung fields. The infant shows moderate respiratory distress with nasal flaring and subcostal retractions. What does this auscultatory pattern suggest about the underlying lung pathology? Option A, central airway obstruction with complete atelectasis. Option B, diffuse alveolar disease with air trapping and inflammation. Option C, pleural effusion with reduced breath sounds. Option D, pneumothorax with absent breath sounds. The correct answer is option B, diffuse alveolar disease with air trapping and inflammation. The auscultatory pattern of widespread wet inspiratory crackles and expiratory wheezing in Meconium Aspiration Syndrome indicates diffuse alveolar involvement. Meconium causes both mechanical obstruction and chemical pneumonitis, leading to inflammation throughout the lung parenchyma with characteristic air trapping from partial airway obstruction. Key diagnostic points. Wet crackles indicate alveolar fluid and inflammation. Expiratory wheezing indicates air trapping from obstruction. A diffuse pattern indicates widespread lung involvement, and chemical pneumonitis arises from meconium components. A clinical pearl. The combination of wet crackles and wheezing together helps distinguish Meconium Aspiration Syndrome from other causes of neonatal respiratory distress. Case 6. Oxygenation and shunting. A newborn with Meconium Aspiration Syndrome is being monitored in the neonatal intensive care unit. Pulse oximetry shows a preductal oxygen saturation of 95%, a postductal oxygen saturation of 88%, and a saturation difference of 7%. The infant appears cyanotic around the mouth and has mild respiratory distress. What does this oxygen saturation pattern indicate about right to left shunting? Option A, no significant shunting present. Option B, mild right to left shunting through the ductus arteriosus. Option C, severe right to left shunting through the foramen ovale. Option D, normal oxygen saturation distribution. The correct answer is option B, mild right to left shunting through the ductus arteriosus. The normal saturation difference between preductal and postductal measurements is less than 3 to 5%. A difference of 5 to 10% indicates mild right to left ductal shunting. In this case, the 7% difference suggests elevated pulmonary vascular resistance, but not yet severe persistent pulmonary hypertension. The pathophysiology is that meconium causes pulmonary vasoconstriction, increasing right heart pressures. An important clinical pearl, monitor the trend over time, because an improving saturation difference indicates resolving pulmonary hypertension, while a worsening difference requires escalation of management. Case 7. Radiographic patterns. A chest radiograph of a term newborn shows hyperinflated lungs with diffuse patchy opacities alternating with areas of hypertransparency. The diaphragm appears flattened, and there are bilateral coarse infiltrates with areas of atelectasis. What radiographic pattern is most consistent with this presentation? Option A, transient tachypnea of the newborn. Option B, respiratory distress syndrome. Option C, Meconium Aspiration Syndrome. Option D, congenital diaphragmatic hernia. The correct answer is option C, Meconium Aspiration Syndrome. The classic chest X-ray findings include hyperinflated lungs with a flattened diaphragm, patchy diffuse infiltrates with a cotton wool appearance, alternating areas of opacity and hypertransparency, air trapping with increased lung volumes, and possible pneumothorax or pneumomediastinum. This is distinct from respiratory distress syndrome, which shows a ground glass appearance with low lung volumes, from transient tachypnea of the newborn, which shows parahilar fluid lines with normal or slightly increased volumes, and from a normal newborn X-ray, which shows clear lung fields. The cotton wool or patchy appearance results from areas of atelectasis mixed with hyperinflated regions due to ball valve airway obstruction. Case 8. Sudden deterioration. A 39-week term infant with Meconium Aspiration Syndrome is on mechanical ventilation in the neonatal intensive care unit. The infant was stable on moderate ventilator settings with a fraction of inspired oxygen of 60%. Suddenly, the infant's oxygen saturation drops from 94% to 78%, peak airway pressures increase from 28 to 38 centimeters of water, and the infant shows agitation and increased work of breathing. On physical examination, breath sounds are markedly diminished on the right side compared to the left, and the chest appears asymmetric with reduced movement on the affected side. What acute complication should be suspected immediately? Option A. Pulmonary interstitial emphysema. Option B. Pneumomediastinum. Option C. Pneumothorax. Option D. Ventilator-associated pneumonia. The correct answer is Option C. Pneumothorax. This is the most common air leak complication in Meconium Aspiration Syndrome, with an incidence of 15 to 33%. The mechanism is ball valve obstruction leading to hyperinflation and then alveolar rupture. Clinical signs include sudden desaturation and decreased breath sounds. Risk factors include high peak inspiratory pressures, positive pressure ventilation, and underlying surfactant dysfunction. This is a true emergency requiring immediate chest decompression. The management algorithm is recognized using sudden hypotension, decreased breath sounds, and desaturation. Confirm with chest X-ray or bedside ultrasound. Decompress with needle thoracostomy at the second intercostal space. Midclavicular line if tension pneumothorax is present. Drain with chest tube insertion, then adjust ventilator pressures immediately. Air leak complications occur in up to 40% of severe cases. Case 9. Primary mechanism of pathophysiology. A fetus in utero experiences hypoxia during prolonged labor. This triggers gasping movements, leading to aspiration of thick meconium-stained amniotic fluid into the airways. The aspirated meconium immediately causes partial airway obstruction and initiates chemical pneumonitis within the lung parenchyma. Which pathophysiological mechanism is primarily responsible for the initial lung injury in Meconium Aspiration Syndrome? Option A. Surfactant inactivation due to meconium lipids. Option B. Airway obstruction from meconium plugs. Option C. Chemical pneumonitis from inflammatory mediators. Option D. Persistent pulmonary hypertension due to fetal circulation. The correct answer is Option B. Airway obstruction from meconium plugs. Meconium aspiration creates a cascade of lung injury through multiple mechanisms. The primary mechanism is mechanical obstruction. Thick meconium creates partial airway blockade. The ball valve effect allows air in but restricts outflow, and this results in hyperinflation and air trapping. Secondary effects include chemical pneumonitis from inflammatory mediators, surfactant inactivation by meconium components, and pulmonary vasoconstriction leading to persistent pulmonary hypertension of the newborn. A key teaching point: Meconium Aspiration Syndrome injury occurs in 3 phases. Phase 1 is mechanical obstruction. Phase 2 is chemical pneumonitis. Phase 3 is surfactant dysfunction. Understanding this sequence guides targeted management at each stage. Case 10. Surfactant inactivation. A 39-week newborn with Meconium Aspiration Syndrome is intubated in the neonatal intensive care unit. Laboratory analysis of tracheal aspirate reveals high concentrations of free fatty acids and proteolytic enzymes from meconium. The surfactant to albumin ratio is significantly reduced compared to normal values. Pulmonary function testing shows increased surface tension and progressive alveolar collapse. What is the primary consequence of surfactant inactivation in Meconium Aspiration Syndrome? Option A. Increased lung compliance. Option B. Decreased functional residual capacity. Option C. Improved ventilation perfusion matching. Option D. Enhanced oxygen diffusion across the alveolar membrane. The correct answer is Option B. Decreased functional residual capacity. The surfactant inactivation mechanism works as follows. Meconium contains free fatty acids and proteolytic enzymes that directly inactivate pulmonary surfactant. Loss of surfactant increases alveolar surface tension, which leads to alveolar collapse, and the result is decreased functional residual capacity. A critical clinical impact: surfactant dysfunction reduces lung compliance by up to 40% in severe cases. This is why exogenous surfactant therapy can be beneficial in moderate to severe Meconium Aspiration Syndrome cases, as it aims to restore the normal surface tension-reducing function that the endogenous surfactant can no longer provide. Case 11. Inflammatory cascade. A term newborn develops severe chemical pneumonitis following meconium aspiration. Laboratory analysis shows elevated neutrophil count and increased inflammatory markers. Bronchoalveolar lavage reveals activated immune cells and cytokine release. Meconium contains bile acids and enzymes that trigger a massive inflammatory response in the lungs, leading to tissue damage and impaired gas exchange. Which inflammatory mediator is most strongly associated with the development of chemical pneumonitis in Meconium Aspiration Syndrome? Option A, interleukin-2. Option B, interleukin-6. Option C, interferon gamma. Option D, tumor necrosis factor alpha. The correct answer is option D, tumor necrosis factor alpha. Tumor necrosis factor alpha is the primary inflammatory mediator driving chemical pneumonitis in Meconium Aspiration Syndrome. Released by activated neutrophils and macrophages, it triggers a cascade of pulmonary inflammation and tissue damage. Its key mechanisms include activating neutrophil recruitment and adhesion, increasing vascular permeability leading to pulmonary edema, stimulating production of other inflammatory cytokines, causing direct alveolar epithelial cell damage, and promoting surfactant inactivation. Other cytokines play supporting roles. Interleukin-6 triggers the acute phase response. Interleukin-1 beta causes fever and inflammation. Interleukin-8 promotes neutrophil chemotaxis, and interleukin-10 has a protective anti-inflammatory role. Elevated tumor necrosis factor alpha levels correlate with disease severity and predict development of persistent pulmonary hypertension. Case 12. Persistent pulmonary hypertension of the newborn development. A newborn with Meconium Aspiration Syndrome develops severe hypoxemia that does not improve with oxygen therapy. Echocardiography shows right ventricular hypertrophy and a right-to-left shunt through the foramen ovale and ductus arteriosus. The infant requires mechanical ventilation with high fraction of inspired oxygen. What is the primary mechanism linking Meconium Aspiration Syndrome to persistent pulmonary hypertension of the newborn? Option A, pulmonary vascular resistance increase due to hypoxia and acidosis. Option B, left to right shunting through the patent ductus arteriosus. Option C, ventricular septal defect causing volume overload. Option D, systemic vasoconstriction from sepsis. The correct answer is option A, pulmonary vascular resistance increase due to hypoxia and acidosis. The pathophysiology of persistent pulmonary hypertension of the newborn in Meconium Aspiration Syndrome follows a specific cascade. Hypoxia triggers pulmonary vasoconstriction. Acidosis amplifies vascular smooth muscle contraction. Increased pulmonary vascular resistance develops. Right-to-left shunting occurs through fetal channels, and this creates a persistent fetal circulation pattern. The mechanism is hypoxia plus acidosis lead to pulmonary vasoconstriction, which leads to increased pulmonary vascular resistance, which leads to persistent pulmonary hypertension. Echocardiographic findings in this condition include a dilated right ventricle, a D-shaped interventricular septum, tricuspid regurgitation, and right-to-left shunting. Most importantly, Meconium-induced hypoxia and acidosis create a vicious cycle of worsening pulmonary hypertension that must be broken. Case 13. Blood gas analysis. A newborn with suspected Meconium Aspiration Syndrome presents with severe respiratory distress. The infant requires mechanical ventilation with high oxygen requirements. An arterial blood gas is obtained showing the following results. pH 7.22, partial pressure of carbon dioxide 68 millimeters of mercury, partial pressure of oxygen 45 millimeters of mercury, bicarbonate 18 milliequivalents per liter, and base excess -8. What does this arterial blood gas profile indicate about the infant's respiratory status? Option A, metabolic acidosis with hypoxemia. Option B, respiratory acidosis with hypoxemia. Option C, mixed acidosis with hypercapnia. Option D, respiratory alkalosis with hypoxemia. The correct answer is option C, mixed acidosis with hypercapnia. Let us interpret this arterial blood gas systematically. The pH of 7.22 indicates acidemia. Normal range is 7.35 to 7.45. The partial pressure of carbon dioxide of 68 millimeters of mercury indicates hypercapnia, confirming respiratory acidosis. Normal range is 35 to 45. The bicarbonate of 18 milliequivalents per liter is low. For pure respiratory compensation, we would expect approximately 28 to 30, so this confirms simultaneous metabolic acidosis. The base excess of -8 further confirms the metabolic acidosis component. The partial pressure of oxygen of 45 millimeters of mercury confirms hypoxemia, normal being 50 to 70 millimeters of mercury. This mixed combined respiratory and metabolic acidosis is common in severe Meconium Aspiration Syndrome with perinatal asphyxia. Critical management point. Mixed acidosis requires both ventilatory support to correct hypercapnia and correction of metabolic acidosis. Do not treat as isolated respiratory acidosis. Case 14. Oxygen therapy strategy. A term newborn with Meconium Aspiration Syndrome presents with respiratory distress. Physical examination reveals tachypnea, nasal flaring, and subcostal retractions. The infant has a preductal oxygen saturation of 85% on room air. The medical team needs to initiate oxygen therapy to achieve appropriate saturation targets. What is the most appropriate initial oxygen therapy strategy? Option A. Administer 100% oxygen via face mask immediately. Option B. Begin high-frequency oscillatory ventilation with 60% fraction of inspired oxygen. Option C. Start supplemental oxygen to maintain oxygen saturation between 92 and 97%. Option D. Initiate nasal continuous positive airway pressure at 8 centimeters of water with room air. The correct answer is Option C. Start supplemental oxygen to maintain oxygen saturation between 92 and 97%. The respiratory support escalation pathway in Meconium Aspiration Syndrome is as follows. First, room air assessment. If saturation drops below 92%, begin supplemental oxygen targeting 92 to 97%. If supplemental oxygen is inadequate, escalate to continuous positive airway pressure at 5 to 8 centimeters of water. If that fails, escalate to mechanical ventilation. In cases of severe persistent pulmonary hypertension, add inhaled nitric oxide and high-frequency oscillatory ventilation. A critical warning: avoid 100% oxygen because hyperoxia worsens pulmonary vasoconstriction and causes oxidative injury. A clinical pearl: a preductal versus postductal saturation difference above 10% suggests right-to-left shunting and requires urgent assessment. Case 15. Long-term outcomes. A 3-year-old child who survived severe Meconium Aspiration Syndrome as a neonate now presents to your clinic. The parents report that over the past 18 months, their child has experienced recurrent episodes of wheezing, especially during viral respiratory infections. The child has required bronchodilator therapy on multiple occasions and has been hospitalized twice for respiratory distress. What is the most likely long-term pulmonary complication associated with Meconium Aspiration Syndrome? Option A. Bronchiolitis obliterans. Option B. Reactive airway disease. Option C. Pulmonary fibrosis. Option D. Chronic interstitial pneumonia. The correct answer is Option B. Reactive airway disease. Children who survive severe Meconium Aspiration Syndrome are at significantly increased risk for developing reactive airway disease, manifesting as recurrent wheezing, chronic cough, and exercise intolerance. This occurs due to inflammatory airway remodeling during the acute phase. The risk of reactive airway disease is 2 to 3 times higher than in the general population, typically appearing within 6 months to 5 years of age. Chronic lung disease risk is 1.5 times higher, appearing at 1 to 12 months. Recurrent pneumonia risk is twice as high in the first 2 years of life. Exercise intolerance is variable and typically becomes apparent at school age. Most children show improvement by school age, but pulmonary function tests should be performed at 6 to 12 months follow-up for severe cases. We invite you to join our Pediatric Case review community and unlock exclusive educational resources. Our complete library of case-based lectures is all organized by medical system for easy navigation, so you can access every video in one place. All high-resolution presentation slides are available as downloadable images for offline study and review. You will also have access to additional practice questions and clinical cases to review, annotate, and master at your own pace. To get full details on how to subscribe, simply comment below this post, and we will message you directly with all the information you need. We have now completed our comprehensive case-based review of Meconium Aspiration Syndrome. Let us review the 5 key takeaways from today's lecture. First, early recognition saves lives. Always look for meconium-stained fluid and immediate respiratory distress at delivery. Second, prompt oxygenation targeting 92 to 97% oxygen saturation prevents further complications. Avoid 100% oxygen. Third, gentle ventilation with prolonged expiratory times reduces air leak risk, which affects up to 40% of severe cases. Fourth, persistent pulmonary hypertension of the newborn management with inhaled nitric oxide is essential in severe cases. Fifth, long-term follow-up is necessary because survivors have a 2 to 3 times higher risk of reactive airway disease. Please follow Pediatric Case Review for more evidence-based lectures covering all pediatric systems. If you have questions, drop them in the comments below. We are here to support your clinical practice.